Notre intervenant suivant est Francesco Prada, docteur Francesco Prada, qui travaille à Mesta à Milan, qui est un institut de neurochirurgie. Francesco est lui-même neurochirurgien. J'ai eu le plaisir de le rencontrer quelques jours à Charlottesville, puisque c'est lui qui m'a remplacé quand je suis revenu en France. Voilà. Donc, Francesco, je ne sais pas si tu m'entends bien.
Oui.
Voilà.
Oui, oui, je vous entends très bien.
Oh, il parle très bien français, mais il
Non,
est un petit peu... Il a proposé quand même de faire sa présentation en anglais. Donc,
so, do you see my slides?
Yes, we do. Go ahead. Thank you, Francesco.
Ok, bonjour à tout le monde. Merci Cyril et merci Gilles pour cette opportunité de présenter les applications neuro des ultrasons thérapeutiques. Seulement la première slide est en français. Et je suis désolé. Et je suis désolé aussi de ne pas vous joindre en personne. Ça sera pour la prochaine fois, j'espère. Et je ferai le reste de la présentation en anglais parce que sinon ça prendra trop longtemps. So in the neuro application are comprise a really wide array of application and technologies that I will first describe how to deliver the ultrasound to the brain, and then I will provide some examples of the actual and established clinical application in some of the neuroenvironment. As Cyril mentioned, I'm a neurosurgeon, but all these applications, they cover not only neurosurgical or surgical problems, but they also tackle neurological conditions that do not have currently a surgical treatment, such as Alzheimer's disease or psychiatric disorders. This is a slide that has been used in the previous presentation as well. It's from the Focus Ultrasound Foundation, and it presented the global landscape. And as you can see, the application of therapeutic ultrasound tackling neurological problems are quite numerous. Some are in the preclinical stage, some are already have approval both in Europe and in the US for treatment. And they are really, they cover basically almost all neurological conditions. But the first question that we have to address when we talk about treating and delivering ultrasound to the brain is the problem posed by the presence of the skull or the vertebrae if we want to treat the spinal cord. As you know, the skull absorbs 90% of the ultrasound energy. It deflects the ultrasound and reflects the ultrasound. Therefore, ultrasound delivery is complicated to treat to focalize precisely ultrasound to the brain. And as a matter of fact, the role of ultrasound in the diagnostic realm for neuro application is limited mainly to Doppler imaging through specific ultrasound window, acoustic windows such as the temporal bone, the orbital window, or the occipital window, but it's not always possible anyway to perform such investigation. This problem is partially solved when we use ultrasound for intraoperative guidance, and the reason is that we basically cut out the skull, and then this provides a true acoustic window to the brain, and as a matter of fact, ultrasound, I mean imaging, ultrasound for imaging and for surgical guidance is becoming a real workhorse in the OR, and not only it's useful for surgical guidance, but it also provides a way to study directly the brain with ultrasound in an unprecedented manner and in a multimodal manner. So this is a slide I stole from Cyril. Similarly to imaging ultrasound devices, also the therapeutic devices have many different features. They can have different probes, different shapes, different frequencies for different pathologies. As I will give you some examples later on, and of course different acoustic sequences. And we have three main ways to deliver therapeutic ultrasound to the brain. I would say the probably most established one is the MR guided, and in this early stage I think it's also a useful device because it provides real-time feedback with image guidance, with direct image guidance, with MR guidance, and the MR guidance is the and the MR is the best option for is the best diagnostic tool for neural application. Then we have navigated devices, which are based on pre-acquired images. They have a more flexible approach, and then we have implantable devices that can deliver the ultrasound energy directly or through other implants. This is an example of the Exablate Insightec Exablate system. This is a stereotactic device. Probably it's the most precise stereotactic device to date. It has MR guidance. So it's quite a cumbersome tool to use, but it's very precise and it allows to perform optimal planning. And also provides real-time, quasi-real-time feedback because they have cavitation detection and thermometry when we use this device at high frequency, let's call it high frequency, to perform lesioning. And cavitation detection when this system is used with a low frequency to perform blood-brain barrier opening. Of course, it's not readily available, and there are few centers that can offer this kind of treatment. This is an example of how, I mean, I cannot explain this equation, of course, but this is just to show how the technology is pivotal into focalizing ultrasound through the skull. With this device, we have more than 1,000 elements, and the machine calculates the deformation generated by the skull of the patient and tries to correct the aberration, synchronizing the phases of the different elements. Navigated devices are, I believe, a really useful tool. There is, I think, one device. There are devices throughout the world under development. They relies on a single element transducer, which is navigated. And this is quite useful and familiar to us neurosurgeons because we use neuronavigation daily in the OR. So it's more familiar than an MR guided system for neurosurgeons, for sure. So most of these systems do not have a real-time feedback, and probably they're a bit less accurate. They cannot provide phase correction. Phase correction can be implemented, but this is also another early stage technology. This is from the Physics for Medicine lab study. There are acoustic lenses that are under development. They are built on the again on the CT according to the CT data of the patient, and they are able to deformate the beam before they are redeformed by the scalp, so that in the end, minus plus, the equation is 0, and the machine is able to focalize the beam correctly. Implantable devices there are two solutions currently. One, of course, is the SonoCloud system developed by Cartera, and this is a device that is implanted at the time of surgery, first or second surgery. For this is mainly for brain tumor treatments. The ultrasound transducer is implanted directly in the scalp, and then it's activated at the moment of the treatment. Of course, it requires a surgical procedure, so it goes against the mantra of the incision-less surgery, but I think these are really useful devices in the transitions towards this. Another option is to implant an artificial acoustic window instead of the native cone of the patient, that would allow for post-operative ultrasound follow-up. Here you see an example in a patient harboring a glioblastoma. You can see both the B mode and the microbubble are visible. And in the future, the idea is to perform not only patient follow-up, but also ultrasound-guided, ultrasound-mediated therapies to the brain. So switching gear and jumping to clinical applications. This table by Choi and Kim again shows how wide the therapeutic options, possibilities are according to the type of ultrasound that we use. If we use a high intensity for tissue ablation or low intensity with only exploiting mechanical properties of the ultrasound, we can generate many different mechanisms of action, ranging from tissue ablation to PPB opening, sonodynamic therapy, or stimulation. And we can address different kind of pathologies. Certain type of certain mechanisms of action are really appropriate for certain pathologies, such, for example, tissue ablation for functional neurosurgery. But I believe that always there is a sort of an overlap. For example, in sonodynamic therapy, we exploit chemical mechanism when we use ultrasound in combination with a sensitizer, but also there is a mechanical, so probably there is an overlap, and this has to be better understood for sure. So few examples. Functional ablation is by far at the moment the most established treatment modality for neuro application. It relies on the concept of focalizing energy through the scalp in a short period of time in a continuous manner in order to generate heat. One of the issues is that this is possible through the scalp only in a limited area, so to speak. As you can see here, the treatment envelope is limited to the central areas of the brain where the basal ganglia are, and therefore this is where we have to intervene when we want to interrupt pathologic circuits, neural circuits. Whereas brain tumors, it has been attempted for brain tumors as well, but they fall often outside the treatment envelope. The first attempt was performed to treat patients was performed in Urbana. This is still a preclinical application by the Fries brother, but this is where the concept of neurosonic surgery started. The first pathological condition that was addressed, probably because it was also the easiest and more clear to understand, was essential tremor, where we have a tremor of one or both upper limbs. And this was the pathology that was treated first. The area that is treated is the VIM nucleus in the thalamus, and a series of paper. Basically, they were all these studies were performed at the University of Virginia in Charlottesville by Dr. Jeffrey Elias. They paved the way to the FDA approval in 2006. And actually, there are studies trying to understand whether this option is better than deep brain stimulation, which is at the moment the gold standard. For sure, this is a true non-invasive treatment and is being adopted more and more, for sure. And the number of studies evaluating the efficacy and the quality of life of patients is growing worldwide, with many studies worldwide, and also this is a procedure that is approved and reimbursed in many areas. Similarly to essential tremor, Parkinson's disease is another pathology that is being addressed to treat and control the tremorigenic component of the Parkinson's disease, not the degenerative at the moment. There are multiple targets that they all fall within the treatment envelope I showed you earlier. So there have been attempts to perform thalamotomies, pallidotomy, or recently trial by, again, Dr. Elias and Obeso, they addressed the subthalamic nucleus. A recent meta-analysis showed that the HIFUture is for sure effective in improving the tremor for Parkinson, and it's not inferior to DBS to evaluate tremor suppression. Psychiatric disorders. These are another category of brain disease or mental disease that are being addressed and under investigation. Of course, there is a little bit of reluctancy due to the let's say overuse of frontalumpectomy in the past. For sure, this is, again, it's a non-invasive modality, lesioning the areas of the anterior limb of the internal capsule, or the cingulate gyrus, or the accumbens gyrus, the accumbens nucleus, are being under investigation to treat OCD, obsessive compulsive disorder, and major depression. And there is a phase 1 trial ongoing in this regard to performing ultrasound capsulotomy. Okay. Pain is neuropathic pain in particular. Central pain is again another target for functional ablation. This has been pioneered by Daniel Jean Monod in Zurich. Again, the target falls within the treatment envelope because the target is a central lateral nucleus of the thalamus, or other authors are targeting the centromedian nucleus. There are different ongoing trials, apart from the one from Jean Monod in Maryland and at the University of Virginia. And my hospital is part of one of these trials as well, to tackle neuropathic pain. It is also possible, and to perform a neuromodulation with ultrasound using a low-intensity pulse ultrasound, and the use of low-intensity pulse ultrasound is under investigation in order to study the possible response of the patient to an eventual ablation. Neuromodulation, as I said, is a modality that uses low-intensity ultrasound. Is very precise, can go deep within the brain. It's even probably more precise than TMS. And the mechanism of action is not completely understood. Probably it acts on the neural membranes and on the ion channels, and this allows to perform a modulation of the brain activity. There are clinical experiences showing mood alteration and alteration of the connectivity, and there are trials undergoing studying again obsessive compulsive disorder and major depression. Moving to neuro-oncology. So brain tumors are another big burden for our patients. In my hospital, we mainly treat the patients with brain tumors. The thermal ablation was initially used to tackle brain tumors, especially glioma. The first report was in 2006 by Sviram and colleagues in Israel, where they performed ablation of a glioblastoma, but this was through a craniotomy. So it was not transcranial. Then the first other reports using MR-GFUS are by McDonald in 2009, but the trial was discontinued because a couple of patients experiences some major issues. And the last to report an ablation, a successful ablation, is Colucci in 2014, without the need of a craniectomy. There are currently 3 trials ongoing. What's going on? Okay. But more interesting, probably for brain tumors, is blood-brain barrier disruption. So the idea is to deliver microbubble and activate them within the vasculature. And as you know, the cerebral vasculature of the brain is sealed, and this prevents drugs and other therapeutic agents to extravasate and being delivered to the brain. So this is pivotal because few drugs are available, few therapeutic options are available for example, glioblastoma. Whereas opening the blood-brain barrier would allow us to deliver more efficiently the chemotherapy. And there are numerous trials ranging from safety and feasibility to efficacy of BBB opening. The first studies were performed in Toronto using the MR-GFUS system. Then again, there is the option to use implantable devices for recurrent brain tumors, where it has been shown that the survival was improved using this approach. And there are new trials published and ongoing testing other drugs such as temozolomide or etoposide. So the interest is really growing, and we have 2 trials ongoing in my hospital. One is the maintenance study with temozolomide, and the other one is going to test irinotecan. Using the MRGFAS for BBB opening still is kind of cumbersome, because for multiple times the patient needs to have the head fixed in a stereotactic frame. So probably for BBB opening, more agile solutions such as implantable device are envisaged. The BBB opening, or let's say microbubble mediated interaction with the tumors, also has another very interesting effect, which is that of potentiating the liquid biopsy. The group by Hong Chen in Washington, they did some preclinical study showing that the antigen released by the tumor after sonication with microbubble dramatically increased, facilitating the detection of this antigen. And there is a study, a clinical trial, again in Toronto, first in human proof of concept study, that showed that liquid biopsy can be enhanced with microbubble and focus ultrasound. Another modality that is very interesting and applicable to brain tumors is a sonodynamic therapy, where basically the idea is to exploit the interaction between a sensitizer and the ultrasound. Both agents are harmless per se. Their combination generates on one side a chemical damage because they create reactive oxygen species, and also it exploits the enhanced the mechanical damage. In neuro-oncology, we know and we use great sensitizers such as 5LA and fluorescein, because these drugs are used for direct surgical guidance under fluorescence. And here you can see a couple of examples of glioblastoma, 5LA in purple and fluorescein in green. And they both accumulate selectively in the tumor, so they do not extravasate in the brain, and they can be deemed the perfect sensitizer for sonodynamic therapy. Preclinical studies clearly showed that the sonodynamic therapy is able to reduce the tumor size in vitro, and based relying on these experiences, 2 clinical trials are on their way, one in Phoenix and one in Milan, using in both cases 5LA to treat recurrent high-grade glioma and de novo glioma in the other case. Lastly, ischemic stroke, another example that this has been perfectly addressed in the previous lecture. Stroke as both ischemic and hemorrhagic is a major burden worldwide, and the idea, as it has been explained before, is to in one hand try to destroy the blood clot using the oscillation of the microbubble coupled with the ultrasound, elicited by the ultrasound. In the case of ischemic stroke, in order to revascularize the brain areas affected, and also this is not yet in the clinical realm, to tackle the hemorrhagic stroke with ultrasound in order to dissolve blood clots using HIFUture to mechanically liquefy the blood clot, then aspirate it or leave it there. And this is still in a preclinical realm, but it's probably soon due to start using an HIFUture helmet, which is under development. So this is from a slide from 2018, and as you can see, as I mentioned before, essential tremor and functional procedures for the brain cover the most outnumber by far the other procedure for ultrasound procedure for the brain diseases. But for sure, this is going to change with brain tumors and treatment for psychiatric disorders. And also, I didn't mention, for the sake of brevity, the option to perform BBB opening in Alzheimer's disease. Of course, this is still under investigation, but this is going to change, and the number of procedures for sure is going to increase dramatically in the next years. So in the presentation, I tried to give you an overview of the possible application and all the fields in where we are studying application. Of course, we have different pathologies, different needs, different treatment modalities, and different devices, and we have to find the proper one for each problem. There are some interesting and open questions, such as do we always need focused ultrasound? Can we use unfocused ultrasound? For sure, we need to better understand the underlying mechanism, because, as I mentioned, in the sonodynamic therapy, we for sure elicit a chemical mechanism, but also there are the mechanical mechanisms that should be taken into account, as for blood-brain barrier opening, where the extravasation of the drug for sure is able to kill tumoral cells, but also we know that we elicit an inflammatory response, which is usually covered by the tumor. So there is probably an overlap and a need to better understand this mechanism. And the goal for the brain, or probably also for the other organs, but is to perform incision-less surgery. But I think we are still in the early stage. Therefore, such as we do with radiotherapy for brain tumors, we will need to start studying the option of combining different therapeutic modalities. So I would like to finish with a quote that from Nathan McDonald, which is one of the guru in micro BBB opening, that I liked very much and I found very interesting. If half of this is true, it's fantastic. And thank you for your attention.
Thank you, Francesco. So we have time for a couple of questions. And if you are remotely connected, don't forget to ask questions in the chat. Une question dans la salle.
Morning, Francesco. It's Dr. Philippe. I have a question for you. I'm quite impressed by the amazing results of essential tremor with the patient that are walking after the treatment. But I imagine that it's quite disappointing for a surgeon like you to not be able to access to peripheric lesions, as I think it's more frequent. How do you think you can overcome this problematic of the black zone on the sides? And is your prosthetic window that you show on your presentation could be an option to reach these lesions?
Thank you. That's a great question. Yeah, but I mean, The thermal ablation, I'm not sure, for example, that thermal ablation that is used for essential tremor is the proper way to treat brain tumors, for example. So I'm not worried much about the fact that we cannot reach the periphery. There are low frequencies mediated therapies that can access the periphery more easily. So I think, for example, in the future, maybe histotripsy would be an option to treat the brain tumor, even peripherally. Although I am kind of reluctant and worried about liquefying a 5 centimeter in the diameter tumor and leave it there in the brain. Having said that, I think, for example, for BBB opening or other ultrasound-mediated therapies, implantable devices are more agile. So the Cartera device already showed that it's effective. The prosthesis added the fact that opened the way to performing ultrasound-guided ultrasound procedures. So I started using intraoperative ultrasound 10 years ago, and my, let's say, teacher was Gigi Solbiati. He's an oncologist and he does a liver procedure, and he showed me how ultrasound guided procedures are easier and faster and cheaper compared to CT or MR guided procedure. And I think that having this option would be great. Of course, also because the MR guided system are really expensive and not everyone can have access to this kind of treatment modality. Whereas with the prosthesis and with the development of ultrasound probes such as the butterfly probe, which is you can connect your probe to your mobile. This will allow to have more centers performing these procedures.
Thank you. One question. I'm going to ask one then. Are you aware of any application of ultrasound on peripheral nerves? And would it be interesting on doing that?
Yes, I don't do much peripheral nerve surgery, so this is not one of my main interests, but I know that there are studies to treat neuropathic pain through peripheral nerve stimulation. I think Elisa Conofago at Columbia University is addressing this issue, and we are thinking also of performing sonodynamic therapy in neurofibromas, peripheral neurofibromas, because we published a paper recently showing that neurofibromas uptake fluorescein. So we are thinking about this option to treat with ultrasound guidance peripheral nerve tumors.
Okay, thank you. Thank you. Just one more question. Yeah, just a question. I would like to know, in Italy, how many HIFU centers are available in Italy? Because we said yesterday in France, it's a very limited number of centers. So in Italy, is it very?
Yes. We have, I'm talking only about brain systems. There are 5 brain systems in Milan, in Padova, L'Aquila, and 2 in Sicily.
And they treat only brain pathology,
no.
Or also treat, because we have been with Cyril to the European Oncology Institute in Milan, and we have seen radiologists who treat benign disease like myoma also in their centers.
No. You're correct. There is another HIFU system at the Orthopedic Institute in Bologna and one in Rome. And we had another body system two body systems in Milan that are not working anymore.
Thank you. Merci, Francesco. That was a great review. and hope you can next time if we organize it again.
Sure, no, okay, for sure. Thank you.